This is Professor Monte Buchsbaum. He is really a great expert in the field of neuroimaging. Professor Monte Buchsbaum is a distinguished professor of psychiatry and radiology, emeritus professor of the University of California in San Diego. He is also a mentor of Professor Konstantinos Fontoullakis. He is also the founder and editor of a very famous journal, peer-reviewed journal in psychiatry, named Psychiatry Research. So it's our honor, it's our pleasure, it's our good luck really to have Professor Monte Buchsbaum with us. And I just want to say that citations, if you can imagine, it's 46,450 for publications of Professor Monte Buchsbaum. And the Hirsch index is 120. So we are very impressed, and we welcome you at the stage of our webinar. Thank you so much for joining us, Professor Monte Buchsbaum.
I would like to welcome you also, Monte. Thank you for being here with us. And as Daria said, I appreciate very much that you stand as my mentor in my early years. Thank you for being here.
Thank you very much for having me, and I'm anxious to participate in this new electronic way of meeting colleagues and telling them about new ideas. Dr. Soros has presented an excellent introduction to the problems of adapting neuroscience to the clinical treatment in depression. And he has kindly shown an article from my journal in his work on the amygdala. And he's also featured the work of Dr. Mayberg, predicting drug response from metabolism in the cingulate gyrus, something we have also demonstrated in a published article. So the question, as I look back on what is now half a century of brain imaging, is why haven't things like Dr. Mayberg's work been clinically widely accepted? And why aren't we using brain imaging to make clinical progress in treating schizophrenia? And this is going to be a somewhat critical review of our overall viewpoint on how we use biology to understand treating patients. So for instance, let's look at the current viewpoint. WebMD says tests to use to diagnose schizophrenia. The doctor may want to do a urine or blood test to be sure that alcohol isn't involved. The doctor may want to make a brain scan to rule out other problems like brain tumor. Where is the use of brain imaging to diagnose and treat the patient with schizophrenia or depression? It's not listed. It's not even considered. Dr. Kashavin has a review, Neuroimaging in Schizophrenia, 2020. Individually observed abnormalities across psychiatric disorders are not sufficiently specific yet to be of diagnostic value. So as of half a century after the first brain imaging results, imaging is not valuable yet. Is this really the right viewpoint? Now, here's the kind of thing that Dr. Kashavin and others look at. Here's a circuit analysis, which is statistically significant, showing differences between patients with schizophrenia and healthy patients. And there's a lot of overlap. And if you look at the little dots carefully from this study by the Chinese group, you'll see that 17 patients were lower values than all but 4 healthy. So there is a statistically significant difference, but there's a lot of overlap. And so people say, well, this is not a specific enough test. We can't really use brain imaging yet. Now let's take a look at the coronavirus. The coronavirus, we use biological tests. In fact, we depend on them because it's very difficult to make the diagnosis of coronavirus versus influenza. You can't do it on a physical exam. The history is unclear, and so is the chest x-ray. Only a laboratory test can be used, and it has to be sensitive and specific. Now, the WHO says, well, you can make a clinical diagnosis of coronavirus, but really to confirm it, you must have a laboratory test. Now, how good are the laboratory tests? Well, we can look at the sensitivity and specificity of, for instance, PCR tests. And 62% of people are true positives. So if you select people who had some symptoms, that's the pretest probability up in the upper left-hand corner, and then you administer the coronavirus test, 62% are true positives, and 18% are false negatives, and 1 is false positives, which means you got 19 people wrong. So we're willing to accept for coronavirus a test that gets 19 people wrong because we believe that the biology is preeminent. Not the symptoms, not the cough, but the biology is preeminent, so that we know that if the person is positive, they have coronavirus disease, and we're willing to accept a certain number of errors. Now, how does this viewpoint get expressed in psychiatry? In biological testing, we make a decision about quarantine. We decide whether to shut down the university. We decide whether or not we're going to use remdesivir or whether we're going to use dexamethasone. So we make clinical decisions, and those clinical decisions are based on the biological test, the biology of the coronavirus, not on the characteristics of the cough, not on how many times the patient breathes per minute, but on the virus test. Nothing is used in schizophrenia. No drug choice, no prognosis, no hospitalization decision is made on the basis of imaging. Why are these two fields of medicine so different? Well, what has the last half century of brain imaging brought us to understand about schizophrenia? Well, it's brought us the fact that there is reduced brain volume in schizophrenics, reduced activity in the frontal lobe and also reduced volume, diminished dopamine binding in the thalamus, which could be relevant to drug response, reduced white matter organization, which could be the thing which would be of help with deep brain stimulation by substituting for defective circuits, as Dr. Soares has just shown, and reduced size of the thalamus and the temporal lobe, which might also be indicators of other biological roots. Let's start with the oldest finding, fluid-filled ventricles. And the ventricles in the center of the brain, if they're large, it means, since the skull is a fixed size, that it must be that the brain is getting smaller. And this was the first real finding in brain imaging and psychiatry. Large ventricles were associated with schizophrenia. And this was the work of Eve Johnson, a psychologist. And this was found to be irrelevant by neuroradiologists who failed to actually quantitatively measure the ventricle. But as a psychologist, Eve broke away from this, measured the ventricles, and found that the ventricles were small in schizophrenia. And this has been replicated in 72 studies in meta-analysis. So this is very clearly established as one of the biological correlates of schizophrenia. Now, a second development was looking at activity in the frontal lobe. And David Ingvar initiated this work in remarkable studies of regional blood flow in patients with schizophrenia. And this was published in Scientific American, 1974. And patients with schizophrenia failed to activate their frontal lobe when they put their hand in a bucket of ice and felt the coldness. So Dave Ingvar came to the NIH and worked with me on the first PET fluorodeoxyglucose studies, which enable us to look at directly at metabolism in the frontal lobe in 3 dimensions. And we used the positron emission tomography technique, in which a subject receives an artificial sugar, fluorodeoxyglucose, carries out a psychological test, and then is moved to the PET scanner. The fluorodeoxyglucose is taken up by the brain and held in the areas that are active in proportion to how hard they're working, and then the three-dimensional slice-like images can be seen. And what happened was that patients with schizophrenia showed the same thing as the blood flow studies of Dave Ingvar, namely that patients with schizophrenia had less activity in their frontal lobe up there at 12 o'clock than the typical healthy volunteer. And actually 3 areas in activation have been identified as low in schizophrenia in a lot of scientific reports. Low areas in the frontal lobe, the caudate nucleus, and the thalamus, suggesting a circuit involving frontal activity, motor activity, and attentional behavior working together in schizophrenia to be in deficit. And here we can see in a little more detail the normal control more active in the frontal lobe, the patient with schizophrenia less active in the frontal lobe and the cingulate gyrus. And this may be some overlap with some aspects of depression, in that the cingulate gyrus is also affected in patients with depression, as shown in Dr. Sora's report. Now, the interesting thing about positron emission tomography is you can not just see fluorodeoxyglucose as a measure of glucose metabolism, but you can image receptors with tracers that have a similar chemical structure to antipsychotics or other drugs. So drugs go to a receptor. A modification of the molecule can make a molecule that will stick to the receptor. This molecule can be labeled with a radioactive isotope, and then a picture of the receptor activity or receptor density can be made for many different neuroreceptors. So this gives us the opportunity of identifying not just dopamine schizophrenia, but serotonin schizophrenia, glutamate schizophrenia, and eventually in depression, serotonin abnormalities, NMDA abnormalities, et cetera, for each of the potential causes that Dr. Soares showed on his slide 7. His slide 7 showed a variety, maybe 5 or 6 different possibilities for diseases that would cause depression. And the viewpoint has been that these are multifactor, all working together, rather than we're looking at 5 separate illnesses that ought to be addressed as separate biological illnesses. Why aren't we looking at serotonin disease in depression? Or I should say serotonin disease. Why aren't we looking at dopamine disease, the things we know how to treat and have science behind them? Now, in positron emission tomography and schizophrenia, obviously, we're interested in the dopamine system. And a tracer named falopride is a tracer which is like a neuroleptic. It sticks to the dopamine receptor. If there's a lot of dopamine present, it can't stick to the receptor. So we have a way of measuring the amount of dopamine in the synapse or the density of the receptors. And we can see this in the falopride scan. We can see that the caudate nucleus and the thalamus are really hot and the cortex are low, because the density of dopamine receptors in the cortex and other areas of the brain are much lower than that in the caudate and the thalamus. And so we'll be able to see whether the changes in glucose metabolism are in some way echoed in the changes in the dopamine system. And here we have, again, the dopamine falopride scan superimposed upon a standardized MRI, so that you can see the exact anatomical location, the weak activity in the thalamus, although still somewhat like 4 to 10 times the density of dopamine receptors that's found in the cortex. Now, it's also important to note that if the density of the dopamine receptors in the frontal cortex is a 10th or a 20th as great as the caudate nucleus, the frontal cortex is 10 to 100 times as big as the caudate or the thalamus. So there may actually be more dopamine receptors in parts of the frontal cortex than there are in the striatum. And we have to consider looking at all of the brain areas with appropriate mathematical models to look at dopamine, serotonin, and the other receptors in every part of the brain. So here's the model. You can see the dopamine receptor here. The dopamine ones are the little yellow or ivory colored ones fitting into the red receptors, and phalopride's the blue triangle. And if there's dopamine in the receptor, it can't bind. If there's no dopamine, it can, and then we get a high value. So we're expecting to see that if schizophrenics have a lot of dopamine or too much, then they'll have less binding of phalopride to the striatum or thalamus. And this is in fact what now 4 different research groups in Sweden, Japan, and the United States have found that there is reduced binding of high affinity dopamine receptor ligands in the thalamus and in some cases in the striatum. All right, so now we're thinking about how are we going to use this to treat patients with schizophrenia. We have sensory input coming into the thalamus, activating the frontal lobe. Circuits through the striatum and pallidum and thalamus form a loop, a kind of sensory thermostat, modulating how we pay attention, how excited we are, how we can focus our cognitive skills on the task at hand. I'm focusing my cognitive skills on getting the arrow to change the slide. I have to get it exactly in the center of the arrow. So that we can see the striatum pallidum, important, rich in dopamine, motor systems, motor deficits. If this circuit isn't working, you can have motor problems of various kinds. The frontal lobe involved in executive functions, planning and organizing things, knowing that the schedule of the website conference today might change. So I wanted to sign in an hour and a half in advance in case there were changes. This is what the executive function does. And this is what makes the difference between successful lifestyle and job and interpersonal relations and the difficulties that patients with schizophrenia have. So we're going to look specifically at the thalamus, sitting in the center of the brain. And we're going to look at it in different ways. So we've been able to look at its activity, its metabolic activity. We've been able to look at its dopaminergic activity, and we'll be able to look at its white matter connectivity. Now, magnetic resonance imaging gives us advantages that PET does not have. It gives us a picture of structure, which is very detailed. It gives us the picture of fractional anisotropy, a measure of how aligned the white matter fibers are, and enables us to trace the white matter fibers through the brain. And it also enables us through what is called functional magnetic resonance imaging to look at different areas of brain activity. So first, let's take a look at structure in schizophrenia. And for instance, the thalamus is found to be reduced in volume in a whole series of studies. So you can trace the thalamus on the MRI scan and then three-dimensionally reconstruct it. And in this case, the red areas show shrinkage of the medial dorsal nucleus and the pulvinar specifically. And we can also show, using the traced thalamus, we can show areas in the thalamus that have reduced metabolism. And if you look in the lower row of serial sections, it's the area of the medial dorsal nucleus, which shows the greatest metabolic reduction. And the medial dorsal nucleus is the part of the thalamus most intimately associated with the executive areas of the frontal lobe. And we know that there are many direct pathways connecting the medial dorsal nucleus to integral areas of the anterior and middle frontal lobe, which enable various kinds of cognitive activities to be carried out rapidly and successfully. And in fact, some of these medial dorsal frontal fibers may be especially the ones that are used in tests that are used in cognitive batteries of schizophrenia. So the medial dorsal nucleus is a special area of interest, not only in cognitive performance, but because it has richness in dopamine receptors, a target for drug action. Now, magnetic resonance imaging for fractional anisotropy shows us the alignment of the white matter fibers. And it provides, through complicated mathematical applications to the MRI, an ability to see fibers that are actually closely aligned or closely disorganized and pointed in different directions, less prominent, defective in various kinds of ways. And fractional anisotropy has been widely used in imaging of schizophrenia. And many of the areas of the brain involved in the white matter fibers in the frontal lobe have been found abnormal. This is our first study, but a number of studies have replicated difficulties in fractional anisotropy in the white matter of the frontal lobe and in the branches of the internal capsule that carries the thalamic radiations into the anterior frontal lobe. Now, fMRI studies have also been widely used to show changes in the temporal lobe. And what we have here is not just the blood flow levels, but statistical analysis of areas of the brain that have decreased blood flow and by inference, decreased metabolism. And this shows clearly the temporal lobes on both sides affected. And lastly, we can look at the correlation between different areas so that if the thalamus and the frontal lobe are disconnected, then if the thalamus is activated but the frontal lobe is unrelated in activity, then we may infer a connectivity deficit. And just to demonstrate this, I took this illustration of decreased activity in the medial dorsal nucleus and the frontal lobe, and using our own data on unmedicated patients, showed that healthy volunteers had a positive correlation, that is, more activity in glucose in the medial dorsal nucleus was associated with more activity in glucose in that area of the frontal lobe that was shown in the fMRI illustration. And the reverse occurs in 25 never medicated patients. So this suggests an abnormality in the communication. In the normal, the medial dorsal nucleus is turning the frontal cortex on, and in the patient with schizophrenia, it's turning the frontal cortex off. So this is another kind of deficit that can be seen. And with these cortical deficits in communication, we address the idea of whether or not, how is it that drugs would work? If the connectivity is wrong, maybe this would suggest that drugs couldn't work at all. It's part of the wiring of the brain and obviously couldn't be changed by the neurochemistry. On the other hand, since we know that antipsychotics work, at least in some patients, we can infer that the drugs may help repair defective circuitry. And if the dopamine circuitry is defective and the medial dorsal nucleus of the thalamus is sending the wrong messages to the frontal cortex, then by blocking the activity of dopamine in the thalamus, we might free the frontal lobe to be its executive self. And this is a model that would be supported by this kind of connectivity distribution. Now, there have been a lot of connectivity analyses lately. This is the most popular thing in 2020. And there are actually, I found 5 very large connectivity studies published from scientists, all 5 in China. And they had more elaborate models than I've just shown you I just showed you univariate correlation coefficients that I did in preparation for this talk from our old data. These people have used very elaborate mathematical multivariate models. And what have they shown? They've done sensitivity and specificity, just like coronavirus. And what they show is they get a fair number of true positives, a lot of false negatives. And so we see something which would be pretty useful for detecting some patients with schizophrenia, but not others. Now, of course, this is a global model that might accommodate several different kinds of biological mechanisms in detecting the false positives and false negatives. So it's not a model in which we're specifically addressing whether thalamic frontal deficits are present, and therefore we need a dopamine drug, or therefore we need to insert one of Dr. Sora's electrodes into the thalamofrontal connectivity areas if the person has a deficit on fractional anisotropy. So this is not a specific model, and maybe that's why it has so many false positives and false negatives. But there's an even a greater problem that we haven't really faced up to, and that is that sensitivity and specificity are measured against clinical diagnosis. So the clinical diagnosis is based on talking with a diseased brain. And if you look at it this way, the €1 million scanner can never be as correct as a psychiatric interview, because the psychiatric interview is the gold standard. So it's bound to have lower sensitivity and specificity. And therefore, no biological measure can ever match a psychiatrist talking to a schizophrenic for a few minutes and making a diagnosis. And therefore, the question is, how can we trace the biological underpinnings of schizophrenia just through verbal production and through guessing whether or not a PET scan or the fractional anisotropy is a useful measure of what we want to do with the patient. So the question is, there's this little pink dot. Is that patient healthy or not? Now, the biological measure is equivocal. It's based, remember, on whether or not this is correct or not. It's based on talking to the person, not really based on a specific analysis of a connectivity deficit. We don't know really whether this is the sensitivity or specificity that these individuals, Dr. Zhang is publishing, has any real meaning. And what is diagnosis for? It's to select among alternate treatments. It's not just to know this person has schizophrenia and this person doesn't. It's to decide, what are we going to do? It has some possible application and prognosis and other things, but the main thing for today is to decide what kind of treatment should this person have. And the same thing is obviously true in depression, where there's serotonergic drugs, noradrenergic drugs, deep brain stimulation, etc. Which one of those things should we choose? For which disease does the person have? And surely the choice of which disease or which drug is going to be used is based on the underlying biology more than it is a committee-based, verbal interview-based diagnosis. Now let's look at chest x-rays. We have tuberculosis, pneumonia, pneumothorax. They have different patterns, and so we can make a diagnosis on the basis of the chest x-ray. We use the history sum and we combine this with the imaging to make a diagnosis, and these three diseases have very different treatments. They all affect lung function. They all have, if you measure the chest capacity, there's more white where there should be black. But we don't use the black-white index to decide on our treatment. And we certainly don't say the black-white index isn't perfect, because I can diagnose tuberculosis by talking to the person, seeing if they met any people with tuberculosis, how much they cough, and the pneumonia person, does he have a fever? I don't really need imaging at all. And the black-white diagnosis of counts of voxels is not very useful. So we need to think about this in analogy. We want to have a specific diagnosis for a specific treatment. And we want to see the pattern of pneumonia and possibly combine this with bacterial tests and other symptoms of pneumonia and decide on the treatment, which would be very different from pneumothorax. All right, now Dr. Coriel has current treatment options. And I made a typographical error there. I think it's this article is 2020, not 2002. And he writes, Marjorie is a 47-year-old female diagnosed with schizophrenia at age 25. She's taken several antipsychotic agents and gained weight with risperidone, olanzapine, and quetiapine. Okay, or BMI and so forth. And he asked the question, should the person get A, aripiprazole, B, aripiprazole acting injectable, C, olanzapine, D, risperidone? All right, now that is a reasonable question. If you were a first-year resident, you'd be sitting there in your room wondering, well, what should I do with this person? And of course, she hasn't been on a bunch of antipsychotics that aren't listed on that list. Those would be possibilities. Aripiprazole is a partial agonist and may be effective in patients who have different kinds of dopamine abnormalities. Olanzapine has some serotonergic effects. Risperidone is more dopaminergic than some, possibly than olanzapine. It would seem as if the brain biology might play some sort of role in this choice of this drug or other drugs. There was no answer in the article. The article was wait for the FDA to come up with some new drug. There is no guideline. Dr. Lally reviewed work and said there exists small and robust efficacy differences between medications, and response and tolerability to each antipsychotic drug varies. There's no first-line antipsychotic drug that is suitable for all patients. This is true, but this could be true because different patients require different drugs. And double drug or triple drug comparisons to see whether or not an individual patient responds better to a specific drug have really not been carried out adequately. So we really don't know whether to choose one drug or the other. Now there's data from randomized studies that shows that drugs are more or less equivalent, but that could be because dopamine and serotonin and glutamate and NDA receptor diseases are more or less equally distributed in the heterogeneity of schizophrenia, and so drugs who have multiple receptor effects can't really be differentiated except by using specific biological probes. All right, so in our circuit, if there's too much dopamine, we might want to use a dopamine antagonist. And there are dopamine pathways in schizophrenia that involve largely the caudate, the thalamus, and the frontal cortex. Clearly, if you have a thalamo-frontal cortical caudate abnormality, you might want to choose a dopamine drug. Now, if you give haloperidol, you get a dramatic effect. You can see in nearly every patient that you do a PET scan on that the metabolism in the basal ganglia and the thalamus increases, and this is thought to be because dopamine is inhibitory and it's turned off in schizophrenia, and then if you give a dopamine blocker, then you see greater metabolic activity. And in our studies, at least, nearly every single individual administered a drug showed this effect. Now, in our study, we had randomized 25 patients to either haloperidol or placebo for 5 weeks, and then placebo or haloperidol. And we got PET scans at week 5 or 10. So one PET scan was off drug and one PET scan was on drug. And what did we find? We found that responders to haloperidol have low FDG uptake in the striatum following placebo. So if your striatum is low, it means that you presumably have a lot of dopamine. It needs to be inhibited. And if you administer haloperidol, those are the patients who are going to respond. And this is analogous to the Mayberg study, in which changes in the cingulate, an area rich in serotonin receptors, was predictive of drug response. And here it just shows an example, a non-responder high in the striatum on placebo. And we then went on to replicate this in a group of adolescents, 16 adolescents with a diagnosis of schizophrenia and no previous drug trial. This was a randomized assignment trial. And interestingly, we also showed this in patients with obsessive compulsive disorder who were serotonin reuptake inhibitor unresponsive. And these patients also showed in the exact same caudate area a prediction of who would respond to risperidone. And I personally interviewed a number of these patients, and they had symptoms that graded into the psychotic for some of the aspects of their obsessive compulsive disorder. So they were a somewhat abnormal group, but we drove the biology first. If they had low values in the caudate, they were likely to be dopamine antagonist responders. All right. Now, if we really look at different drugs, olanzapine, clozapine, chlorpromazine, and so forth, and their receptor binding profile, we see that these drugs are actually fairly different. And they affect the dopamine receptor, the different varieties of dopamine receptor, histamine, serotonin, muscarinic receptors, each one differently, and they have quite different profiles in their activity. So surely we ought to be able to take advantage of this activity profile and combine it with PET scanning and make a more biological, straightforward, rigorous, scientific assignment of the patient to the particular drug. Now, I realize there are limitations in this, and I realize that the radioactive ligands in PET scanning are not totally specific. Falopride affects both the D2 and the D3 receptors. We don't have a fully as great a specific D1 receptor ligand, but in the future, as we develop more specific ligands, as we have for serotonin receptors, with the 5-HT2A receptor, or for glutamate, then we'll be able to make even more specific diagnoses. But this shows us why the drugs are different, why shifting a patient to a different drug might be valuable, and why we need some science to guide the choice of the many, many drugs. All right, now here's a Danish study. This study looked at actually dopamine receptors in the frontal lobe and found they were able to predict from a dopamine ligand which patient would improve on a conventional antipsychotic. So this is another indication of the PET strategy to select the individual patients. All right, now what about glutamate? So glutamate has been raised as a possibility in depression, and glutamate disease could also be part of the psychotic syndrome. Now, there are different ways of measuring glutamate. You can measure it through spectroscopy with the magnetic resonance imaging techniques, and usually these are restricted to small boxes of area. So you can't get enough signal in order to image the whole brain, but you can image part of the brain. There are techniques that have been proposed for whole brain imaging that may be fairly effective. And there are also glutamate receptor drugs that have been introduced for PET that can show where the glutamate receptors are. And you can see it's quite a different pattern than we see with falopride or glucose. All right, so magnetic resonance spectroscopy, a study showed the left thalamus was significantly negatively affected with % change in positive symptoms. So these people who have low glutamate are candidates for glutamatergic drugs. And we could identify them with spectroscopy specifically. So here we're looking not at schizophrenia, not at diagnosing schizophrenia, but at finding a specific neurochemical deficit and treating it with a relatively specific treatment. This is the clinician question. What drug shall I try first? And this is the question that brain imaging may be able to address. All right, now here is an elegant study, decreased serotonin 2A receptor density in schizophrenia. And they found that healthy subjects had higher values than patients in this study. Now let's look at this study very carefully to see why it is brain imaging hasn't made as much progress as it should. They did 6 healthy patients and 6 healthy and 7 patients. And if you look at the little maps of where the t-tests are significant, it's very clearly all the way across the frontal lobe. So these are people with serotonin disease. They have an abnormality in serotonin receptor density in their frontal lobe. Their frontal executive is presumably then defective, and they need some help in dealing with this probably genetic deficit. Look at the average value across the entire cluster. You see that you get a value 3.82 in healthy, 3.25 in patients, and a t-test of 1.74, almost statistically significant. So the center of the cluster had a high t-value in the 3s, but the whole cluster as a whole was 1.74. All right, now let's look at a simulation using their means and standard deviations and a sample size of 25. We see that we could identify 5 patients below any healthy subject. The red dots are the schizophrenics that are simulated based on the mean and standard deviation of Dr. Hilton's work. And you can see that the schizophrenics spread across the entire range of normals. There are ones that are higher than normal and ones that are lower. But there are 5 patients below any healthy subject with a sample size of 25 schizophrenics and 25 normals. And so 20% of the population then might be inferred to have serotonin disease. We don't want to call it schizophrenia disease. Now, if we look at what would happen if 10 universities tried to repeat Dr. Helton's work, and they did the same sample size of 6 and 7 patients, then we can see in a simulation that 6 of the 10 universities would report that it was not statistically significant. And that would be the end of serotonin PET scanning in the world. And this is the difficulty with small samples and with the failure to acknowledge the concept that schizophrenia is a biologically heterogeneous disease with many different potential neurochemical causes. And this is where the field has floundered over the last half century. In schizophrenia in Europe and America, there are 500 million people, which means approximately 5 million patients with schizophrenia. And if 5-HT2 disease is 20% of schizophrenia, then 1 million poor responders might be helped with a serotonin drug and not a dopamine drug. So this is where the future needs to head. 1 million patients who are poor responders is a tremendous cost of hospitalization, of inpatient and outpatient care, of loss of tax revenues and productive jobs. And this is something that we have to address. Now, I'm not related to this drug company in any way, but they had a nice picture. And Nuplazid is a new serotonergic agent with no appreciable affinity for the dopaminergic, histaminergic, muscarinic, or adrenergic receptors. And so it's the ideal drug for a drug trial. And here is the future. Identification of serotonin 2A receptor subtype of schizophrenia spectrum disorder with pimavanserin, the sub-zero proof of concept trial. And I've outlined their goal. Neurobiologically, we expect psychotic symptom reduction to be most prominent in patients with low frontal serotonin 2 binding potential at baseline. And this is the approach that is going to bring brain imaging into clinical practice. They're addressing the disease from a biological standpoint rather than the verbal word standpoint. And they're using PET scanning to identify the responders. This is the future, and this is the group Dr. Baltzerin and other people in Denmark, and actually including, I think, Dr. Meltzer as well. All right, now there are different regions for dopamine and serotonin receptors. Dopamine is very high in the caudate and the thalamus. These are low areas for serotonin. Serotonin is mainly a cortex, and the caudate and the thalamus are relatively low. These are ideal contrasts for the two different choices of treatment. So we need biology-driven science. Now, one of the difficulties with this trial is that we really want to answer the question, is it better or worse than a dopamine drug? And by using a serotonin receptor identification, can we also use a dopamine receptor identification and randomize the people into a dopamine blocker and a serotonin drug? So the ideal trial would have been be much bigger, to do 2 PET scans on the subjects, one for dopamine and one for serotonin, and then for randomize them into a dopamine versus serotonin drug response categories. And this is what the future has to bring, to really bring a scientific, rigorous approach to drug choice. The serotonin versus dopamine schizophrenia would be a good place to start. It needs multi-center recruitment and scanning. It needs government, university, and industry support. It needs industry recognition that schizophrenia is not a monolithic disease where one drug, after a lot of study, will turn out to be #1 and be a giant seller. It needs to be a recognition that schizophrenia is heterogeneous and needs different drugs for different people. And the different people can be identified by brain imaging, by various biological tests, possibly by genetic tests as well. And this is what the future has to bring. And we have to bring some of the same urgency to it that we brought to coronavirus and other health problems. Schizophrenia is a giant question and deserves a giant focused approach. Now you say, oh, PET scan's too costly. Who would get a PET scan? You can just try the drug and then try another drug and then try another drug and have a rehospitalization. What is this PET scan stuff? It's expensive. Well, inpatient costs are 200 to 500 euros a day. There's continuing expensive medication with poor response in many patients for years. Patients get financial support from the government, from you and me, equal in cost to many PET scans. And MRI spectroscopy may also, in the long run, or even short run, substitute for PET in trying to sort patients out into their biological categories. Now, what about polypharmacy? Everybody is doing polypharmacy. And it's common, 23% of patients receive more than 5 drugs. In New York, we saw at the VA patients receiving up to 17 psychoactive drugs. These rates increased from 19% in 2000 to 26% in 2015. Excessive polypharmacy with greater than 8 drugs increased to as high as 6%. Now, what's the model of polypharmacy? The model of polypharmacy could be seen, well, they need both drugs because there are multiple causes. But on the other hand, polypharmacy could be seen as a patient has a specific receptor deficit. And if you keep adding drugs, eventually you'll hit one that hits the right receptors in this particular patient. And so polypharmacy really supports the clinical recognition that there's heterogeneity within schizophrenia, and is well modeled by the idea that schizophrenics have a particular neurochemical deficit, which eventually you'll find by adding drugs, a drug which is successful. So polypharmacy teaches us something, but doesn't seem like a particularly useful approach for very elaborate randomized controlled studies, which in fact have not been done. If you have dopamine, serotonin, and glutamate schizophrenia varieties, 1 or 2 or 3 of polypharmacy drugs might work. And a rigorous double-blind polypharmacy study is tremendously expensive because you'd have to have random assignment to various combinations with crossover to really understand whether or not the patient responded on the one particular drug or the other combinations. So the difficulty of carrying out rigorous double-blind studies in polypharmacy is really oppressive, and a more focused neurochemical neuroscience effect is much more appropriate. Now, what have I been doing in the last week? Working on data on 25 never medicated patients with schizophrenia to try to understand the role of the medial dorsal nucleus. And we have a set on these patients. They're all never medicated, and we have 4 scans: FDG and anisotropy, phallopride, and MRI density. So we have 4 variables to look at and to try to see if we can look at the individual differences among these patients on a multivariate basis. And so first we can look on a univariate basis: FDG, phallopride, anisotropy, and MRI. And you can see that the medial dorsal nucleus and parts of the frontal lobe are common to all 4 modalities, but with the usual problems of weakness and variety. Now, we can make then a multivariate prediction of who has schizophrenia from the thalamus using FDG and phallopride. So we're expecting there's going to be low glucose and a low dopamine binding, and the 2 of them together will identify medial dorsal dopamine disease in schizophrenia. And this shows that there's a statistically significant FDG and phallopride multivariate prediction of schizophrenia in the thalamus. Now we can then focus on the thalamus, and I'm going to enlarge this section of the PET scan. And this is new data which no one has seen since I just did this last week as part of our working on this data set. So here we are. We have the thalamus drawn from the Talairac Atlas, and we have for every voxel the prediction for that particular patient of whether or not it's schizophrenic or healthy. So we're looking at a multivariate prediction. If it's red, that is a high value, close to 0.9, it's going to be schizophrenia. If it's a low value, it's going to be healthy. And we can look at a healthy correct then. If we look at the medial dorsal nucleus, we get an outline of the thalamus with the blue areas. So this subject is pretty clearly not a medial dorsal nucleus schizophrenia case. He's a healthy person. On the other hand, if we look at the other person, the schizophrenia person who was correct, then we see that we get the shadow of the medial dorsal nucleus specifically outlined as a place where FDG and phallopride in combination predict the diagnosis. But let's look at the whole group. Well, let's look at this specifically. So here's the model. And this person, if you look at that particular voxel, has a 0.9 value for being schizophrenic, and it outlines the medial dorsal nucleus. So this person is a good example of medial dorsal dopamine disease. This is a patient we'd want to treat, I think, with an antipsychotic which blocks the dopamine receptor, and we want to send him back to a productive life, a job, a spouse, and a life on his own. Now here are the 19 in the lower row, the 19 healthy and the 25 patients with schizophrenia. And in the upper row, the 19 normals, you'll see they have large blue areas in the thalamus. So that area then on a multivariate basis is predicted as being that they are healthy. And if we look at the 25 schizophrenics, you'll see that there are fewer ones, although there are some with blue areas in the thalamus, and there are areas, the majority or at least half have pretty good red values that is predicting to be schizophrenia in the medial dorsal nucleus, but it's really the 4 leftmost ones that are the most unequivocal. So there's a whole range of heterogeneity, but there's certainly some subjects who are positively predicted to be medial dorsal disease. And these people should have the advantages of a dopamine serotonin, a partial agonist versus full agonist trial to see whether or not this kind of thing can focus and give a scientific and rigorous basis to our drug choice. And it also dramatizes the individual differences that we see. While there are statistically significant group effects, the individual differences are large, and we want to be able to target, to personalize the individual differences in schizophrenia toward personalized and individual treatment. We want to treat these patients differently. We found them, and we want to really know who we want to treat, and we want to do it on a scientific basis related to their biology. Peter Buckley wrote, as stated earlier, despite many robust pharmacogenetic studies, treatment selection remains a joint decision by patient and doctor based on more on intuition and experience than any biological distinction. This is highly problematic. And I agree. As of December 2017, we should have made more progress, and the way is open for pharmacogenetic studies, for doing what Dr. Soares did of inserting electrodes into the brain in places where fractional anisotropy specifically shows a circuit deficit, and for targeting the serotonin form of, I hate to say that, serotonin form of schizophrenia. I want to say serotonin disease as a cause of psychosis. We want to personalize this, and it's highly problematic that we've had brain imaging and pharmacogenetics for half a century without making more progress on this. And this is the goal for everybody who's listening, to try to help to organize bigger, better, more focused scientific studies to understand the heterogeneity of schizophrenia, to personalize our treatment using genetics, brain imaging, deep brain stimulation, electrical recordings, to really understand individualizing treatment and understanding the course of this disease. Thank you all very much.
Dear Professor Monte Buchsbaum, thank you so much for your lecture. Not just Professor Kostas Fontolakis, but all of us will fall in love with you and with your lecture. Thank you so much for detailed explanation on many, many issues regarding the brain imaging of schizophrenia. And we have a few questions as the team of Global Events and Harris show at the screen.
Okay, so we have a first question from Dr. Maren Kempf. How do patients with serotonergic and dopamine schizophrenia differ clinically in terms of their symptoms? This is a very good question that has not been answered at all. And this would require a cohort of patients who received dopamine and serotonin PET scans and then being analyzed for their symptoms. And this would be very interesting and informative, but has not been done. And so this is not an emphasis in the research approach, and is a very important question, and I'd like to see answers to it. So it's an excellent question. Now we have an anonymous question as the second one. Great presentation. In this study with 25 patients with schizophrenia, you distinguished between active positive, let's see, let's see. I have to, the pictures cover up part of the question. You distinguish between active positive or negative symptoms. I'm not sure that I really have distinguished between the symptoms, and it's what the first questioner asked about. Can we really see symptom correlates of the distinctive biological patterns? And this has been hard to do, and especially has not been integrated into drug trials, so that drug trials have tended not to emphasize individual difference analysis. So if you look carefully to see whether or not negative symptoms predict the choice between two drugs, this is something in a randomized clinical trial is very hard to find. This was left out of the Katie study deliberately by Dr. Lieberman, and I discussed this with him. And so we don't really have full answers to that question. And I think it's an interesting question because we put so much emphasis on positive versus negative symptoms. We really like to know what the biological underpinnings are vis-a-vis drug response, which is the key thing as a clinician we need to do. And now Dr. Nair says, is there any specific method to identify best drug for the patient, categorizing them? And the answer to that is no. That's my complaint. There isn't any method, and it hasn't been emphasized. And there are very few crossover two-drug studies which have really enabled us to answer this question. And so crossover studies are disapproved of by everyone because it's claimed that there are very long-term crossover effects. And I volunteered to write a chapter for the American College of Neuropsychopharmacology on the reason for crossover trials being scientifically valuable. And they said, no, crossover trials are no good. And so this is why the answers to the first three questions have not been rigorously scientifically addressed, in my opinion, and would be something that should be done. Now, in fact, just thinking about this, if you're in private practice, you could randomize people between dopamine and serotonin drugs, since there is some moment of clinical equipoise. Some of the more serotonergic drugs, and certainly among the spectrum of approved drugs, are quite different. And this question that Dr. Nair raises and the other people might be answered in small individual trials that could be carried out even outside a drug support network. And I would encourage people to think about how large clinical practices and large clinical centers could help to answer some of these questions. It would give us good hints about the proportions of the different kinds of deficits among schizophrenics and who to target for the more detailed PET scan studies. All right, now we have an anomalous question. Did all positive symptoms display dopamine excess in the thalamus? And I do have BPRS symptoms on my subjects, and I will go back and look at this to answer this question. We haven't specifically looked at region by region symptoms in the falipride FDG data. And I can see from the first four questions, this is the first thing people are answering. And when I return to data analysis later today, I will take a look at that and see whether we can specifically look at the multivariate prediction from FDG and dopamine against the 3 BPRS scales. All right, now let's see, then we have another question. again about the symptoms. And this is something I can answer. In some ways, it's not a high priority, but in some ways, it's certainly of great interest. And it's something that I could do, and I'll try to consider making that part of the report I'm writing. Now, Dr. Nair also asked, is there any chance of brain imaging EEG markers in ICD and DSM in the future? Well, I know that years ago, Dr. Andreasen fought to have brain imaging included, brain imaging characteristics such as enlarged ventricles included in DSM. And her opinion was not accepted. And I see a low chance of accepting these things because there's definitely the feeling that there's a lot of, quote, false negatives and false positives. We're not willing to consider the possibility of brain shrinkage disease, for which the CT scan or EEG would be extremely successful. Now, I might also want to mention that EEG is extremely sensitive to drug effects and has not been as exploited as it could be. And to my knowledge, the only double-blind two-drug crossover trial that predicted drug response has been conducted for serotonergic work using EEG, not using brain imaging. And I would encourage the possibility that EEG, which is so sensitive to drug effects, be used in drug trials in which two drugs are given in a randomized way, and the prediction is made for which of the two drugs is successful. The key question the clinician wants to know is not, is this a drug non-responder, but which drug shall I give the person? And which drug shall I give the person has to come out of a randomized trial in which two drugs are given randomized, double blind. And this type of design is extremely rare. And I would urge people to think more in the direction of this, because this will give us something that's clinically valuable to the first-line physician. Let's see, I don't have any more questions.
May I add that there are some data in support of the use of serotonergic drugs like antidepressants as a done in refractory depression. So it's in accord with your comments, your findings. And also, very interestingly, topiramate, which is a GABA A agonist, seems also to be efficacious for the treatment of azadone treatment in refractory schizophrenia, and it works in the basal ganglia as a GABA alpha agonist specifically. So it's interesting to see how these things will evolve in the future. Daria?
Thank you very much. Thank you very much for your commentary, Professor Kostas Fontolakis. Thank you very much once again, Professor Monte Buchsbaum, for your excellent, amazing lecture and for your precious time. And for
it was a privilege to have you here, Monte.
Privilege, honor, pleasure, everything. Thanks so much.